Our first speaker then will be Dr. Austin Crowe. He's with the Chippewa Valley Orthopedic Sports Medicine Center just next door, and he'll be talking to you, obviously, about robotic-assisted partial knee replacement. So thank you very much, Dr.
That's
Crowe.
right. All right. Is this mic on? Can you guys hear me? Or I'll talk really loud either way. So, again, thank you guys very much for coming out here on a Saturday. I'm sure there's things you'd rather be doing than listen to us talk about knee replacements, but you know, obviously we're always trying to kind of push the envelope and do the most cutting-edge procedures that benefit our patients. I mean, I think we all have the same goal when we see a patient. We want to do everything we can to restore their function, decrease their pain, and give them their lives back. And so we really appreciate you guys coming out here for that today. So, you know, obviously we're going to be talking about just the Mako robot, the system we have here for allowing us to do kind of minimally invasive and precise joint replacements. And we're going to touch a little bit about on the fast track as well, that kind of plan to get patients in and out kind of as quickly as possible. And so, you know, first I'm going to talk just a little bit about robotic partial knee replacements. Then Dr. Stewart's going to talk about the hip aspect, and then we'll have a Q&A session, of course. And I want this to be relatively informal, so if you guys have any questions or concerns, pop your hands up, and we'll be happy to answer them as we go along. So we'll basically just kind of start with a quick overview. I know a lot of this stuff's going to seem fairly mundane, but we just kind of want to touch the basics and then kind of go more into the in-depth stuff. So we're just going to kind of talk about the arthritic conditions that affect the knee. You know, what is a partial knee replacement compared to a total, indications for it, and then what's specific about the robotic partial knee replacement. We'll talk a little bit about outcomes, and then we'll talk a little bit briefly about what fast track is, and then we'll have a time for some questions at the end. So knee arthritis, as we all know, is essentially just inflammation of any joint where two bones come together and articulate. So pretty simple stuff. We all know that. But there are multiple types, and that's an important thing to remember because when it comes to partial knee replacements, they're not all equal. So, you know, osteoarthritis is the, quote, wear and tear arthritis that we see, just age-related. As time goes along, the joint surfaces start to wear down, and that's kind of the standard osteoarthritic picture. There's inflammatory arthritis, so that's a whole host of ones, including rheumatoid, psoriatic, lupus, and you know, a whole host of other ones that have more of an inflammatory autoimmune component. And then there's post-traumatic, so people that have fractures, ligamentous injuries, meniscal injuries, et cetera, that have a traumatic etiology for the wear and tear in the knee. So, you know, as we see normal x-ray, life, boom, that's what we see. This is by far the most common. I mean, so osteoarthritis is going to be the most common patient that we see present. So classic tricompartmental osteoarthritis there. Now, specific to the partial knee replacement are people who have unicompartmental osteoarthritis or post-traumatic arthritis. So these are the patients that have generally, you know, varus deformity, although it can be lateral compartment with the valgus, but, you know, they come into clinic with that classic bow-legged walk. You can spot them a mile away, and then sure enough, their x-rays match that, and you see that predominantly medial compartment wear pattern. So those are the patients that we are looking at. So, you know, again, kind of the 10,000-foot view. What is a knee replacement? Essentially what a knee replacement is we're really just resurfacing the bones. Okay, so we're going to take all the articular surfaces, remove them, and then we place metal on those surfaces and put a piece of plastic in between them. That allows a low friction, low wear articulation. And so traditionally, you know, total knee replacements were kind of the standard for a long time, and those are done by removing all the bony surfaces, so the entire articular surface of the femur and the tibia, and then generally speaking, the patella is resurfaced as well, although that's kind of coming into question a little bit, but generally you're removing everything for that, and that's known as a total knee arthroplasty. So in order to do that, because we're removing all the surfaces, we tend to make a relatively large arthrotomy. So the incision into the knee tends to be bigger. And then again, we talked about the ends of the femur and tibia. Boom, they both go. And then we put the metal and plastic in between them. So this is just a kind of a cartoon picture of that. So we're making cuts. And again, you can see the entire articular surface in the femur, entire articular surface on the tibia. And this one shows the patella as well. And boom, boom. So everything is touched. And of course, in order to do that, we have to have a larger exposure into the knee. And obviously for a lot of patients, that's, if they have tricompartmental disease, that's what you need to do. And so some important things to remember when we talk about total knee replacement is that you're removing not only the articular surfaces, but we're affecting some of the ligaments of the knee as well. Well, I shouldn't say all, but virtually all total knee systems resect the ACL. That's just part of the total knee arthroplasty procedure. If you're doing what's called a posterior stabilized knee, then you're resecting the PCL as well. So, you know, if you don't have an ACL and PCL, you'd think the knee would be sloppy and loose. Well, there's actually stability imparted by the design of the total knee. So there's some congruity between the femoral and tibial components, and that gives a little anterior-posterior stability to the knee. But I think we could all probably agree that piece of metal and plastic probably don't stabilize the knee the same way a native ligament does. And so that's why we see patients after a total knee, yeah, they'll say, my pain relief is great, but maybe my function's not what I'd like it to be. And that's because there's often a little bit of abnormal kinematics in the knee. And you know, the companies have tried to design knees that completely mimic a native knee, but it's difficult to do. So when we talk about partial knees, the thing to remember is that, the knee has 3 separate components: medial, lateral, patellofemoral. And if the disease is only in one compartment, then we can address just that one compartment. By far the most common is medial, followed by probably patellofemoral, then lateral. So we can see those patients who have just unicompartmental disease. So when we talk about doing a partial, we're only taking out that one compartment. So it allows us to do a smaller arthrotomy, so we're just gaining access to one. Although the patellofemoral, you kind of have to do a big one because you have to get under the kneecap. But for medial and lateral, you can do smaller incisions, and then only the arthritic surfaces are being resected. So we're not going in there and taking a saw to everything. We're being very selective. And then, of course, because we're resecting less bone, we're putting in smaller components. So when you look at this, remember kind of that cartoon of the total knee where we're taking everything out. Here, we're just resecting one area, putting in metal on the femur, and then a piece of metal and plastic on the tibia. And so this is, again, going to be much smaller with regards to not only resecting bone, damaging soft tissues coming into the knee. So those are kind of some advantages. So when you look at the x-ray, this is just a AP x-ray of both. Again, you can see this compared to that. So here you've resected all surfaces, and again, importantly, the cruciate ligaments. In this one, you've left the cruciate ligaments alone, and you've just resected, in this case, a medial compartment. So that's kind of the idea behind a partial versus total. So again, just to kind of kick that horse while it's down, less invasive for the partial. We're only resecting the affected bone. We're retaining all ligaments that allows normal kinematics. Yes?
Yeah, backing up to the ligaments, if somebody has medial and lateral ligamentous instability, do you do anything about that in surgery?
So in the setting of a partial knee replacement?
Partial or
Yeah, so the question is if patients have collateral ligament instability. So generally speaking, a collateral ligament instability is a contraindication to a partial knee. In a total, we sometimes can attempt doing reconstructions or some kind of plications, but generally speaking, you're going to be going to a more constrained component. So what I was showing back here, we'll just kind of show a picture. So what I'm showing here is essentially the only really contact between the femoral and tibial component is just the contact of the surfaces. There are components that have either a post that sticks up off this plastic that actually engages into the femoral component. Sometimes they actually link together, called a hinge knee, and those impart stability because the two components are now locked together. Okay, so that can work very well. We don't like to do that unless we have to, because the more constrained the components are, the higher the wear pattern, because then there's not any play in the system. So if your knee's not perfectly balanced, that'll put stress on the tends to be the tibial component, but can be the femoral component as well. So there are things that we can do to address that, but we don't like to. But if someone comes in with a history of a ligamentous knee injury, or heaven forbid intraoperatively we damage one of the collateral ligaments, we have backups, and that's going to be to a more constrained component. And so again, ideally with a partial, we're retaining the ligaments. With a total, it's a larger incision. We're resecting all surfaces, ACL always, and then possibly the PCL removed. And again, it's the components that are imparting stability at this point, no longer the ACL and potentially PCL. So, what are the indications for a partial knee replacement? We kind of touched on this a little bit earlier, but a thing to remember, we all agree that we need to fail non-operative management. We get patients that come in and say, my knee's been hurting for 2 weeks, I need a knee replacement. And you're like, no, you don't need a knee replacement. We need to try things to try decrease your symptoms. And patients can often kind of survive, quote unquote, for quite a while with pretty bad looking x-rays. And so things that we do, injections, anti-inflammatories, bracing, activity modifications, and obviously therapy plays a big role in that. I mean, people always underestimate what strengthening and range of motion can do for a leg. I mean, it's, people, especially when they see their x-rays with bone-to-bone arthritis, a lot of them are ready to just throw in the towel and say, well, there's no hope for me. But we all have seen patients that can persist for much longer than you'd think based on what their x-rays first look like. So it's important not to skip directly to surgery, because patients can get fairly prolonged improvement in their symptoms. And again, I mean, knee replacements, I'd love to think that they last forever, but they don't. So the longer we can delay patients for getting a total knee replacement or a partial, the better off we're going to be. So when you have a patient that has failed those non-operative measures we just alluded to, what are the patients that we can talk about doing a partial on? So we've skipped over the non-op. Now we're talking about operative options for the patients. Patients who have osteoarthritis or post-traumatic arthritis are candidates. So patients who have inflammatory arthritis are not candidates for a partial. And that's just because the disease will progress rapidly. So you replace their medial compartment, and shortly thereafter they're going to have lateral patellofemoral disease, and then you're going to be kind of back at square one. There are restrictions as far as motion and alignment. Patients who have more than about a 10-degree varus or valgus deformity, patients who have more than about a 5 to 10-degree flexion contracture, those ones it's difficult to rebalance the knee because we're not doing aggressive releases. We're trying to, again, be minimally invasive with that concept. So those patients are going to be probably better candidates for a total knee. There's a question about weight and BMI. The studies have been a little bit wishy-washy on this. We do know that with higher BMIs that there's an increased risk of medical complications, but some of the more recent studies have shown that maybe the longevity of the implants are not necessarily affected. I mean, I personally usually look at about a 40 to 45 BMI as my cutoff. But if the right patient, you'll have a discussion with them, and it's something you need to talk about. I mean, some people come in with BMIs in the 60s, and they work their way down into the 50s or high 40s, and they've shown effort on their behalf. Those are patients we'll have a discussion with and kind of talk about, maybe we can do that. But it's something to be cognizant of, that generally speaking, higher BMI tend to have higher complication rates. And again, like we just talked about, there was a good segue before, the ligaments must be intact. So for a partial knee to work well, you need to have the native ligaments there and working. Now, there are some people that occasionally do a ligament reconstruction at the same time as a uni. I have not done that. I've seen them done before. Then you're kind of relying on two different variables, the implants working well and your reconstruction. I'm not saying I wouldn't do it, but it would be something I'd have a long discussion with the patient about. But at some point, you need a stable knee for this to work. So what are the benefits? Again, we've kind of talked about some of these, but again, less invasive, less bone removal, retention of all the ligaments, which imparts better and more normalized kinematics of the knee, less blood loss, less pain during the initial postoperative period, and that all leads essentially to a faster recovery. And so patients who've had partials, they just recover faster, and they feel better, and they feel like a more normal knee. So let's talk specifically about the robot, which is, here's a picture of it. There's the real thing sitting over in the corner. So that is the Mako robot. So, what is the robot? So really what it comes down to is what we're doing is we're essentially trying to do a more precise partial knee replacement or hip, or hopefully at some point a total knee, where we take a CT scan of the knee and we take that information and we upload it into the computer. And now the computer has an exact, basically, dimension, shape of the knee. But of course, the robot doesn't know where the knee is in space, and so that's one of our jobs as the surgeon is to register the knee. So now the robot knows where it is. And so if you look over at the robot in the corner, those two little black eyes right there, those are essentially the eyes of the robot, and that can see what we're doing on the field. And so we have what are called arrays, and so we have them both on the robot itself, the probes that we use to register the knee, and then we actually also put pins in the femur and tibia that now kind of show where the leg is in space. We then take the leg, move it around so the robot knows where the center rotation of the hip is. We mark where the ankle is, and then we actually make our incision, and then we take a probe, and again, now based on this array, the robot knows exactly where the tip of the probe is, and we make points around the knee. And then now it basically kind of links the two together. So it has this picture of a knee in space, and then it maps it against the CT scan that it took earlier. And once they're completely married together and saying, okay, I now know exactly where this knee is, now the robot knows where the knee is in space, and then we can actually begin our procedure. And so with that, we basically can burr exactly the bone we're looking at. So really the precision is based on the ability to use very precise CT guidance along with the intraoperative arrays and registration that we do. And so when we look at that, when you compare the robotic versus the kind of standard or the old way to do partial knees, now this is relatively early data, but the initial stuff looks very promising. So we're seeing lower post-op pain scores, and then probably most importantly, we're seeing more accurate and reproducible placement of our components. Because I think most people would agree that the margin of error for a partial knee is smaller than a total. And so if you have malalignment of your components on a partial, you're probably going to have some early failures. And the ability to be very reproducible with the robot is impressive, to say the least. So when we look at that, just generalized, so what about partial replacements? When you compare them to total knees, they tend to have superior pain and function scores, certainly initially. Shorter hospitalizations, lower complications, lower readmission rates, less blood loss. Now, the one thing to remember, they do have higher revision rates, and this is kind of a sticky subject. I won't get into it too much, but the thing to remember is it's kind of comparing apples and oranges. So if a patient has a partial knee replacement, and at 8 or 10 years they're starting to get some achy pain, you get x-rays and bone scans, they don't show any loosening of the components, often the surgeon will recommend, well, let's revise that partial to a total. Or even early on, patients a year out, 2 years out, there's no signs of loosening or any type of actual mechanical issues, the patient will be revised from partial to a total. Total knees, if the same patient comes in and has normal motion and bone scans, et cetera, workup's all negative, but they're having symptoms, a lot of times we'll just tell the patient, look, you're just having some discomfort after a total knee. Now, on paper, that total knee is a success and the partial knee is a failure. And so when we talk about those revision rates, a lot of people use that as the litmus test for, how is it doing? Is it survivorship is what we use the term. And so when you look at partial versus totals, there tends to be an earlier revision rate for partials. So that's, I think, one issue. The second issue is that we're putting partials in a lot younger, more active patients. And so patients that we're doing them in their late 40s, 50s, they're going to be putting a lot more wear and tear on the implant than patients that are in their 60s, 70s, 80s. So it's a complex topic, but there's no doubt the literature is showing that there's a higher revision rate for partials compared to totals. But again, I think that that's apples and oranges a little bit. Specific to the Mako, that at the 2-year mark, there's only a 1% revision rate, and over the 2-year mark, there's over 90% patient satisfaction rate. So when you compare that to the total knee literature, that's markedly improved. I mean, I think we've all seen plenty of total knee patients. Often their pain relief is very good, but they'll have functional complaints, and those satisfaction scores are pain and function. So you see a much, much higher rate of patients that come in and say, my knee feels like a normal knee. There's a nickname for partial knees is the forgotten knee. You do it, and they're kind of like, yeah, I forgot that I had a partial knee put in. And that's obviously the goal. If we can do that, we're pretty darn happy. So that's kind of the talk about partial knee replacements in the Mako. So what is Fast Track? So really what that is essentially a program that we're putting together for an accelerated recovery following robotic joint replacements. So the goal is discharge within 23 hours of surgery. Some patients, if they go quickly along that track, are going to actually be same-day surgery. So they're going to have their surgery in the morning or afternoon. In the late afternoon or evening, they're going to be going home. And obviously, that's going to take a lot of people working together very closely, and it's a collaborative effort. And that's kind of one of the impetuses for us all being here together is that the therapists play a tremendously large role in this process. So it's basically a synergistic effort by a lot of people to get this to happen. So it's important that we all work together and essentially try to get the patient to have a standardized recovery. And that's really an important thing, and that's one thing that we've been very cognizant of is try to keep it standardized so it doesn't matter if they go, wherever they're going around town, whether it's up to Spooner, over to Chippewa Falls, staying here in Eau Claire, wherever they're heading, that they're going to have a therapist that has the understanding of what the plan's going to be and where we go from there. So that's really kind of what we're looking at, and that's the goal for this plan. What is the ideal candidate? Certainly anyone can be. I put young in quotations. It's all relative. Age is just a number, but there's patients that we kind of recognize that they're kind of motivated and they're physiologically young. Certainly healthy patients, if they have a lot of medical comorbidities, we don't probably want to be doing on a quote outpatient basis. But those are the patients that we're looking at as candidates for a Fast Track. So just real briefly in summary, knees with osteoarthritis that affect one compartment are patients that are candidates for partial knee replacement. Robotic assisted surgery allows precision that really wasn't attainable before. And that's given us at least early and we assume to be long-term improved outcomes with regards to component placement, pain scores, and longevity of components. And so when we look for young patients who are looking for a more normalized recovery, a quicker recovery, and of course have to have unicompartmental disease, those are the patients that we're looking at. And so patients who kind of fit this mold tend to fit into this same mold that they may be candidates for the Fast Track or the Accelerated Recovery Program. And so again, like I just talked about, it requires planning ahead of time and then postoperative communication between the whole team. So that is the quick talk on partial knees. Any questions? Yes?
What are you telling them as far as expectations on how long this will last?
Yeah. So the question was longevity of components. Like when we put them in, how long do we expect a partial knee to last? I mean, I think the literature is showing us that a vast majority of them are going to be around at 10 to 12 years. The literature starts to show a little dip at that 12-year mark. The problem is that what we're talking about is the standard partials. The literature is that far out for the standard. So we don't know exactly. I mean, I'd love to think that the robot is going to allow us to have increased longevity and survivorship of our components. We certainly think that. The early data is proving us right, but it's one of those things we don't know till we're 15 years out, and the robot hasn't been putting in partials for that long. So I usually tell my patients we expect 10 to 12 years. We're anticipating more than that, but it's hard to say for sure. I don't want to tell them stuff that I'm making up. So I try to be honest with them that the literature says 10 to 12 is a very accurate prediction. Beyond that, we expect that, but it's hard to say for certain. Any other questions? Yes.
Is the insurance coverage the same whether it's the traditional versus robotic?
Yes. Yeah. So the question is about insurance coverage for robotics versus traditionals. We have not had a problem with that. There is a separate code that we can put in for robotics, but not all insurance is reimbursed for that. But we would do the procedure nonetheless. So essentially, the procedure, the actual what's called the CPT code for the total knee or partial knee or total hip are all the same. So there's an additional robotic code, but we have not had any issues with that. Yes.
Do people generally tolerate higher impact activity with the partials?
Yeah, so the question is about higher impact activities. The answer is yes, and I think that has to do more with having all the native ligaments. As you're putting a lot of stress across the knee, if you're asking the components to provide stability, I think that creates some dysfunction, and patients kind of feel that knee moving a little bit. I don't encourage my patients to go out and run marathons or do things like that, even with a partial, but I don't have hard restrictions either. And there have been some studies that have looked at patients getting back to doing relatively high-impact activities, and there's not been an effect on survivorship. So if a patient asks me about doing those things, I say, we think it's okay. I'm not going to necessarily give it the thumbs up, but if people want to be active, that's the point of doing these surgeries, to get them back to their lives. So the answer is yes, but kind of negated. So. Other questions? Yes?
Do they tend to get better range of motion back? Are they getting closer to that 130 plus?
Yes. So the question is on range of motion following partial. Absolutely. Yeah, there's no question that patients have had better range of motion. And so are they going to be 100% normal? Probably not, all the way where their foot's touching their butt, but they can get pretty darn close. And the recovery to that point is much quicker. So, we all take care of totals. There's that slow progress at first with totals, and, that 12-week mark, they're kind of getting close to where they're going to be at the finish line or close to it. Whereas with partials, they're kind of out of the gates quick. And there have been patients I see at the 2-week mark that are, you're dang near worried about their incision splitting open. They're bending so far, it's pretty impressive. So, yes.
Is there any decrease in tourniquet pressures or tourniquet times with the robotic? Because it seems like sometimes patients have trouble.
So there's an overall trend in knee arthroplasty, partial and totals, to try to get away from tourniquets, because absolutely people come in with those huge thigh contusions and a lot of pain. Like, what do they do up here? It's like, well, it was the tourniquet. I've been trying to get away from tourniquets during my partial. Now, when we cement, we do put the tourniquet up for a little bit, but that does lead to lower tourniquet times. And, again, with a smaller incision, that allows us to have less blood loss. And so it's allowing us to do these with less tourniquet time. So yes, and then, in part we assume that there's going to be a little bit less quad inhibition, because I think that's one of the big reasons the quad gets shut down, is those long tourniquet times squeezing. It's, you come in and some of those patients have those huge bruises around their leg, and that can't be benign. So, other questions? Yes.
Is there a rehab protocol as far as how fast they can get their motion back, or joint mobilizations with the partial knee?
Yeah, so the question is on range of motion protocol, how quickly we can progress. I don't have a stop on that. Patients will kind of limit themselves. It's a much quicker recovery, and so I suppose if they were like pulse up day 2 going to 130, that might be a little bit much. But I don't have, my protocols are actually the same, so I have the same things that we're trying to work on. So as I progress, I may update that and let it evolve as we progress. But at this point, I don't have a hard limitation on range of motion right off the bat for partials. Other questions? Anything? All right, thank you.